Well, welcome. We've got the piano player to stop for a while. That was kind of nice to have that at the beginning, but welcome. My name is Dr. Greg Meyer, and I'm with the College of Health Solutions. And on behalf of the team that worked it and put together the What We Need to Talk series, and my two colleagues, Dr. Swapna Reddy and Joe Servin, I'd like to welcome you all to tonight's. It's actually season 2. We had season 1 in the fall, and this is our second season of the smash hit, We Need to Talk. It's a series of conversations, healthcare that involves law, media, journalism, and healthcare, where those three things intersect to discuss important subjects and topics. And this is our 4th of the 6-part series. And tonight's topic is titled, as you can see, Saying Goodbye Does Not Have to Be a Struggle. Dignity, Quality, and Expense at End of Life. And this is an area that I've personally been involved with clinically for about 20 years and now have brought some of that experience to the college. To assist us tonight, we have two wonderful moderators. Our first is Pauline Davies, and Pauline is a veteran BBC journalist for BBC's World Today, and also a professor of practice at the Hugh School of Communications on the Tempe campus. And we're also pleased to have with us tonight Mr. Will Stone, who is a senior field correspondent with KJZZ NPR radio in Arizona, which he joined at about 2015. And Will we're just talking about some of the stories that he's worked on, healthcare, behavioral health, some of those juicy political scandals, the opioid crisis, and many, many, many other topics while he's been here since 2015. We have two clinical experts tonight, two physicians that I've known for a long time and have worked with over the years in end-of-life palliative care. And the first is a good friend, Dr. Tom Fitch, who is an oncologist and palliative medicine physician at Mayo Clinic. And he's also the director of their palliative care program for Mayo, Arizona. And then we also have Dr. Gobi Paramanandam. Dr. Gobi was the first graduate of the combined palliative medicine fellowship between Hospice of the Valley, where I worked before, and Mayo Clinic, and that was about 10 years ago, I think we were talking. Gobi is currently a palliative medicine and hospice physician at Hospice of the Valley, but his primary focus is the director of what's called Arizona Palliative Home Care, which is one of the oldest and most established palliative care program in the country. Gobi is also, or Dr. Paramanandam is also a great ASU alumnus, having received his master's in health science management from the W.P. Carey School of Business. So before I turn it over to the moderators and our guests, and at the end, 20 or 30 minutes, we'll have questions and interaction from you all. So we have a short video to set up tonight's topic.
It's me. We need to talk.
100% of all Americans will eventually die. This comes as no great surprise, but the amount of money being spent at the very end of people's lives probably will. Marcia Klish is either being saved by medical technology or being prevented from dying a natural death.
25% of all Medicare spending, more than $100 billion, occurs in the last year of life, in part because patients get aggressive and expensive treatments that don't work.
Tori Barrow's daughter Lena had a rare life-limiting condition, but when she was 7 and her health deteriorated, there was no real plan for the end of her life.
Responsibility lies amongst all of us who at any given time are looking after an individual at the end of their lives.
50 years ago, most people died in their home. They didn't go to the hospital at that phase in their life because they didn't think there was much to offer. Now we always have something to offer.
69-year-old retiree Greg Rogers is healthy and active. With the help of his doctor and a GP, he's filed an advanced healthcare directive.
She had emphysema and lung cancer, and I remembered her liberating me. And I said, I hope I'll be able to liberate her.
What modern medicine is capable of doing is almost what 20 years ago was considered science fiction. Essentially, you can support pretty much every body system for years.
It's a conversation no one wants to have, but you would be wrong to wait for a crisis to talk about the end-of-life treatments such as life support and resuscitation.
Sarah Palin called them Obamacare death panels, and she was vilified for it.
And I think what's so refreshing about that episode is the idea that just because we get older that we don't absolutely have to have a sort of personality lobotomy.
Because you have an illness that cannot be cured.
Videos help to broach a difficult topic and to make it more real and less abstract for patients and their loved ones.
We have a decision to make. One of the decisions is whether we should take the tube from the mouth and take it out. Does he have thoughts about that?
This is one of the toughest issues confronting our healthcare system.
So, Dr. Fitch, as we've seen in the video, end-of-life care raises some very tough issues. Can you talk us through them? What are families and individuals facing as they're coming to the end of their lives?
First of all, I have to say I brought notes because Gobi doesn't have any, but I'm getting old, so remind me of what I wanted to say. I kind of thought about this question, and kind of two things came to mind. One, the video kind of hits at is what I would call medicalization of dying. And I think the other big challenge that families are faced with, there's lots of them, but is the burdens of caregiving. But again, as the video suggested, I think that we, unfortunately, have turned dying into a medical experience. That we've dehumanized the process. As Dr. Gwande mentioned, we always now have something else that we can do. And certainly the science and technology of medicine is, in the last several decades, is not short of miraculous. We can do more and more, and the science is what keeps me going. It's something new every day, you're always learning. But the trouble again is that we have not learned kind of when to stop. The science has led us to to aging. We live longer. The average age now of life expectancy is about 80, a little more for women, a little less for men. But the reality is, with aging comes illness, and often chronic illness. Yes, younger people get illnesses and die of serious illness, but the majority of people live and grow and age, but with that comes chronic illness. And the average person will deal with a chronic illness for about 8 to 10 years. Yes, we'd all like to live until we're kind of 95, 96, die in bed with a loved one. But the reality is that doesn't happen very often. Not many people live well into their 90s. And the opposite is true too. Less than 10% of people in this country die suddenly now. Certainly accidents, the like, and sudden death can happen. But the reality is, again, that most of us age and deal with chronic illness. That's kind of a new disease we've developed as medicine advances as chronic illness, and many people deal with multiple chronic illnesses as they get older. And the trouble that we're dealing with as people deal with chronic illness, get into the medical system, that there becomes a huge gap often between what a person wants, what their own personal preferences and goals and values are, and what happens to them within the healthcare system. That they, when asked, they're often not asked about their own preferences, and I kind of call it the healthcare train. And a good example, and one of the questions maybe later, but is when you ask people where they want to die, well over 80% of people in this country want to die at home when they're faced with a serious illness. And knowing that end of life may not be too far in the future, they want to die at home. But the reality is only about 30% of people die at home. And if you look at a Medicare population with serious illness, in the last month of life, nearly 50% of them will be in an emergency department. 3/4, about 75% of them will get admitted to the hospital. A third of them will end up in an ICU. 20% will have a major operation in that last month of life. And nearly 10% will have a major operation within the last week of life. So again, this healthcare train starts down its track, and a lot of things happen to people that they may not necessarily would have wanted to happen if they really understood the choices. So there's a lack of communication. Again, as Dr. Gwandi mentioned, there's always something that we can do. So I think the big challenge we're faced with is how do we demedicalize dying in this country? How do we bring back a humanity to dying? How do we protect the integrity and privacy of dying? I call that the real art of medicine. When do you stop doing things to people? Because the truth is, there is a point where more care does not result in better outcomes or even a longer life. And there's lots of studies. If you look across the country at matched cohorts of patients, there are places in the country where more care is given for the same disease. Los Angeles, Miami. And if you look at outcomes, outcomes are worse in those cities. So again, doing more is not always the best thing for patients, and doing more can sometimes become detrimental. So I think really that's one of the biggest challenges that people face in this country as they face the healthcare system, and the lack of really kind of honest conversation, a willingness to talk about death and dying, and trying to find out what that personal preferences are of patients and their families.
And Dr. Paramanandam, maybe what can you add to that in terms of when we think about the major challenges facing, these end-of-life decisions?
Yeah, great answer there. And end of life, it's a complex interplay of psychological, clinical, social factors. And that's where hospice comes into play. Many people are aware of hospice, but hospice is for patients at the end of life. And it involves an interdisciplinary team to address all those issues, the symptoms that may come up, the psychological distress, the existential distress that can come with dying, not only for the patient, but for the caregivers as well. But I'm gonna throw this out there to the audience. If you guys, so for hospice, 2 doctors have to say a patient has 6 months or less to live. What would you guys guess the average, or let's say the median length of stay on hospice is for a patient? So if you had 6 months or less, what would you expect the median length of stay? I heard 1 month, 6 weeks, a week. Interesting. So for nationally, it's 17 days is the median length of stay. And then for Hospice of the Valley, we're about 12 to 13 days. So you can imagine that's a lot for a team to try to build a relationship, right? And try to get through all these factors, the psychological, clinical, social. So, what happens is what Dr. Fitch described is these patients, it falls onto, they're getting aggressive treatment. So all of this falls now on a primary care physician or an oncologist or a specialist who, frankly, probably doesn't have the time to address those needs or really the expertise, and doesn't have a team of providers to address it either.
And could you just quickly define, how do you define hospice for folks here so they understand?
Sure. Hospice is designed for patients at the end of life. So I'd say, again, 2 physicians have to say a patient has less than 6 months to live. A patient to get on hospice, it's about the philosophy. So a lot of people think hospice is a place I go to die in the last couple of days of life. And it's really 95% of patients on hospice die at home. They're not going somewhere to die. And a lot of these patients can live fairly long as well. They do have, to get on hospice, you do have to give up aggressive treatment. So a cancer patient would have to give up chemotherapy, radiation to get onto hospice. A dialysis, like a renal failure, right, would have to give up dialysis to get onto hospice. And that's a difficult decision for many people. And I always say it's a philosophy, because in hospice, you're not getting a bunch of labs or images, because you're not treating pictures or numbers, you're treating the person. So if they have more pain, like more back pain, you're not getting an MRI, you're giving them more pain medication, because at that point it's about comfort, dignity, and dying at end of life.
The comments I would make about that, though, is that you're never going to have a randomized prospective study to, is hospice better than not hospice? But there have been retrospective studies. There was a study of nearly 5,000 patients, and they did match cohorts, again, people with similar illnesses and everything else that kind of matched. And 5,000 people, and they looked at those who went on hospice and those who didn't. Now, statistically, that's not a fair comparison, but statistically they did look at that. But the bottom line was that everybody in the hospice group did as well or better than those not receiving hospice care. And some of those were statistically significant. Again, doing that in a retrospective study is not fair. But the bottom line is that people in hospice care get the kind of care they need. It reflects back to what I was talking about, that more and more care at some point is not helpful. It does not result in longer lives or even better outcomes and better quality of life. So what Gobi mentioned too about the late referrals of hospice, I think again reflects back about that old healthcare train is just churning. And then in this country, it's about doing more and doing more. There's always another treatment. So people get referred late to hospice care, when in fact hospice care will actually likely in most instances prolong their life.
But is that because they don't want to give up the idea of curative treatment?
Sure, but at some point we have to be willing to talk about death and dying, and not talking about it becomes a delusion at some point. That we haven't come up with the immortality pill yet. We develop diseases, many of them are incurable, and again, there has to come a point where there has to be compassionate, empathetic, but truthful conversation.
But then there's palliative care, isn't there? So actually, what's the difference between palliative care and hospice? Maybe you can explain.
Yeah, great point. And I'll start with your original question there. So you're right. Some patients struggle with that decision of stopping treatments. And it's interesting, if you look at human behavior, I mean, people cope with things differently, right? So there are always people with positive coping strategies. Probably all of you here probably have some, to make it to this level, right? Positive coping strategies. So, and these patients are optimists, or they understand the reality, or, these are the patients that have bucket lists and know what they want at the end of life. But then you have a group of patients, group of people who have negative coping strategies, like isolation, denial, non-compliance even. And so these are the patients, where, oftentimes I always say, I think this is where our system fails them. If they get on hospice, great, because there's an interdisciplinary team to address all their issues. But if they don't get on hospice, again, it now comes back to the community providers. And that's why palliative care was within the last 10 years, has really grown to address a lot of those issues, the clinical, psychological, social issues that patients have with chronic disease and also at the end of life. We do know, and this I think is another question about finances, but some of these negative coping mechanisms can lead to higher costs, constant hospitalizations, constant ER visits, where palliative care with a team can address those issues and potentially, decrease costs.
So palliative care and hospice, it's not just given in an institution that people have to just go and stay there. This can be in their own home.
Yeah, the majority of hospice care is given in their home. There are hospice, what we call palliative care units, inpatient units, that they're almost like little mini hospitals, that people that are on hospice and have a symptom, pain that's not being well controlled at home, and the family's struggling, they can be admitted to an inpatient unit where there's 24/7 nursing, physicians are in and out, there's a social worker, there's a chaplain. They're not places just for people to die. I am a medical director at one of the HOV palliative care units, and the last time we looked, about 45 to 50% of people that are admitted actually get better and go back home. So it is like a little mini hospital. And as Gobi mentioned, we don't do a lot of x-rays and labs. We can give antibiotics, we can give medications. We take really good care of people. And many times they get better and are able to go home.
And then with palliative care too, so just to build on that,
Yeah.
palliative care, they can continue their treatments, radiation, chemo, dialysis, and get palliative care, which I think was...
I like to define hospice care as palliative care at end of life. And it's again that philosophy of care that people have to be comfortable with to be on hospice. But palliative care, kind of the tenet, and Gobi touched on this, that we pay a lot of attention to physical symptoms, expertise in caring for pain and nausea and loss of appetite and fatigue. But what Gobi mentioned, I wanted to emphasize, we really emphasize what are called other domains of care or determinants of health. That it's a multidisciplinary, interdisciplinary team. We have social workers, we have chaplains on our teams, nurses, nurse practitioners, administrative support. But those other domains include the social aspects of care, kind of the practical, emotional, spiritual, cultural, ethical. We really try to address those issues. And the truth of the matter is, if you look at a pie chart of what affects outcome, you know, the medical care that we spend nearly $1 trillion on accounts for about 10 to 15% of outcome. All those other things I mentioned are much more important. Do they have a home? Who's going to bring them back and forth to their appointments? Who cares for them? Where's their support system? How are they doing emotionally, spiritually? Those have a significant impact on how people do. Other countries pay far more attention to that. In the US, for every dollar we spend on medical care, we spend about 50 cents on all those other determinants of health. If you look at Scandinavian, European countries, for every dollar they spend on medical care, they spend about $2 on those other determinants of health. They have enormous support systems that we just don't provide in this country.
So, Dr. Fitch, it strikes me that, you know, we can it's easy, we know this is expensive, clearly. But in the clip, we had Dr. Gowande say, you know, our goal should be to live a good life till the very end, to the end. So I guess, how do you read that? Because I definitely, when I hear people, you usually hear, I want to live a good long life, or he, she lived a good long life. And so I wonder kind of how you take that statement.
Yeah, I think I almost turn that question around. What's a good death? And I think a good death is a good life until death. That, again, I think the emphasis on palliative care, hospice care, is how do we improve the quality of life for that patient and their families. It's an emphasis on families such that they continue to live their life until they die. That we make the quality of their life as good as we can for as long as we can. And again, there's an openness about discussion of the reality of their illness and what their prognosis is, and really trying to tease out what their own goals and values are and what their preferences are, what are they hoping for, and to try to establish care that fits with what their goals are. You know, there was an article published 2014 in the Atlantic magazine by Ezekiel Emanuel. He's Rob Emanuel's brother. He's a physician. He's a professor of ethics and public policy at the University of Pennsylvania. Well-published doctor. In fact, he has a new book out that's worth reading. The article was the title, Why I Want to Die When I'm 75. It became quite controversial, but I think really misinterpreted, because he wasn't really saying that he wanted to die when he was 75, but kind of getting what I said earlier is that as we age, many of us will develop illness, and serious illness, and maybe several chronic illnesses. And what Ezekiel Emanuel was trying to say is that we need to pause and take stock, because growing older is not always a bed of roses. And you have to start thinking about what you want as those illnesses progress and how you want to be cared for, and a willingness to talk about death and dying. Because if you leave yourself at the mercy of the U.S. healthcare system, you kind of just described of what's going to happen to you.
So you've raised some really interesting issues, what's going to happen to you. And, I quite take on board the benefits of palliative care and hospice, but how do people pay for it? Because this is surely expensive.
Yeah, that's a great question. For hospice, there's a hospice Medicare benefit. So the government created, I think back in the 80s actually, a benefit, and they call it a benefit. So
73.
73, okay, 73, yeah, it's before I was born.
Not before I was born.
Yeah. No, so they actually identify this as an important issue, and so Medicare covers this with no copays. So patients can get this service, so it's nurses, social workers, physicians coming into the home, bringing equipment, if it's hospital beds, bedside commodes, volunteers, whatever they need, it's covered by Medicare with no copay. Basically what Medicare does is they pay hospices $160 a day to cover a person at the end of life. So we always tell patients, you have $160 worth of benefits a day, at the end of life here. And so that's how hospice is.
How much nursing care will $160 buy?
Yeah, I mean, it's at least for Hospice of the Valley, we're a not-for-profit agency, so we provide whatever's needed. I'd say on average, it's about 2 visits a week for nursing. Right. Social worker, maybe once a week. There's a CNA for bathing, maybe twice a week. Volunteers can come periodically for respite care. For example, let's say a patient has dementia, and the wife just can't leave the home because she has to care for this, her patient, her husband basically the whole time. A volunteer could come, interact with the dementia patient, and it's basically respite. She could go shopping, get groceries done, just take some time for herself. So that's all covered under hospice care as well.
There are gaps. And Gobi's right, most government insurance programs have a hospice benefit now, and most private insurers have a benefit. Not everybody has insurance, as we well know. I'll give Hospice of the Valley a toot, in that they spend about $14–15 million a year on charity care. I've never seen, I've been a hem-onc doc here for over 30 years, and I've never seen Hospice of the Valley turn down a patient who's uninsured. But those gaps do exist. That's not always true. There are disparities, racial, ethnic disparities. Blacks don't participate in hospice care as much as others. Middle East, there are gaps. So we don't, there's a lot of research going on. How do we reach out to those populations in a better way? And I've lost my train of thought. Oh, I was thinking rural communities, that, distant communities, small and remote. It's really hard to get hospice out there. Other countries are doing better. Gobi and I have a good friend, a lot of us know a good friend who moved to New Zealand and flies a plane around the southern island of New Zealand for outreach for palliative home care. So.
Yeah.
When you talk, from a system-wide standpoint, we're talking about expenses and, don't leave yourself at the mercy of the healthcare system. Doctor, on a personal level, when you're having these on an individual level, I'm assuming, I don't know, is expense really the concern, or what are the questions or concerns that you hear from folks?
Yeah, great point. And expense often is not the concern or the biggest part we're talking about. So Dr. Fitch mentioned goals of care conversations, and that's a big part of palliative care. And the idea is with every patient who has, whether it's a terminal illness or multiple chronic illnesses, that we have a conversation about what their goals are. So, is quantity of life most important, quality of life most important? And the best example I have of that is I had 2 different patients, right? So having this conversation, 75-year-old guy, stage 4 lung cancer, and said, "Doc, chemotherapy is making me feel ill. I know this is a terminal disease. I'm ready to go." And so for him, that was his goal. His goal was quality of life. So we transitioned him to hospice. He stopped chemo, went over to hospice. He had a bucket list, right? He got all the things he wanted done, and died at home 2 months later with his family around him. That's what he wanted. That was his goal. Had another patient who was 31 years old, stage 4 lung cancer, same situation, had the same conversation. He said, "Doc, I don't really care how the chemotherapy makes me feel. If it buys me another day or two that I could sit on my couch and watch my kids play, that's what's most important to me." So for him, quantity of life was more important. And so he actually kept doing chemo until he was no longer able to get out of bed, and then died on hospice about 2-3 days later. So really the conversation is about, what's most important to you? What are your hopes? What are your fears? And a lot of it's listening,
I mean, I think this is, it's so wonderful, but with an aging demographic, how are we going to cope? Are there enough specialists like you two to help with hospice and palliative care? What is going to be the future when we all age?
Yeah, so we'll get them to talk a little bit. So.
After this question. Yeah.
Oh, I was going to say, anybody remember, of all you guys out there, when was Medicare created? What year? That was 73 was hospice benefit was created. 65. Who was president? Johnson. But in 1965, the Medicare benefit was created. In 1965, there were 20 million people who were 65 years and older. In 2011, so that long time, 50-some years, 2011, there were about 35 to 40 million people 65 years and older. 2011 is an important year because it's a year that people born in post-war baby boomers, born in 1946, turned 65 in 2011. By 2040, so not that long, there'll be over 80 million people. That's me, 65 years and older. So there is this changing demographic, and no, there are not enough palliative medicine physicians. There won't be enough geriatricians, primary care physicians. So we talk a lot about primary palliative care as teaching the skills of palliative care to all physicians, and then specialty palliative care to be a backup. So that's a short answer to a complex question.
And I think also, we're both actually on a committee with Arizona Medical Association, Arizona Osteopathic Medical Association's End of Life Task Force Committee. And so, there's this constant push, obviously, to educate primary care docs, specialists, but we're even looking at the community at large. Could we do events like this to educate people on end of life and what it entails? And obviously, you're a very young group, but even in the, church groups, older populations, get out into the community more to educate people, because a lot of them can have the conversations. And we took a training tool. We're taking a training tool. It's a study. It'll be about 3-4 years. And we're teaching physicians how to have the conversations, but we're also taking it to the community and trying to teach community members that are interested in having the conversation how to bring it up with other community members. And I think that outreach is going to be really important in the near future as well.
Yeah.
You guys are young, but you have parents and you have grandparents.
It's true.
Well, we're going to, I think, turn this over to the audience now, because I'm sure there's lots of questions from the audience, because it's a huge topic. So put your hands up if you've got a question.
Well, since it's the law school, I'll ask a legal question, and that's that or comment that the Arizona State Legislature last session passed a bill, a law, that says physicians can overturn your whatever rights you have as far as doing a living will or saying no extraordinary means or you want to die at a certain time, that for religious purposes, a physician has the right to override you. I don't know how many other states, but Arizona has this. And one of the problems is if you're in a hospital, or I suppose even in hospice, that you may not be able to determine who the physician is, because once you go in the hospital, there's a lot of hospitalists. Your regular physician may or may not be there. And so what's your comment, if you have one, on these laws that are trying to be passed to prohibit people from making this choice?
You're going to have to explain this to me. So a law was passed that if somebody determines how they want to be cared for?
Well, we're talking about the end-of-life issue if you decide that you don't want any extraordinary means,
right,
which could be debatable. Some people think dialysis is an extraordinary means, or various life support systems, and that with the very conservative Arizona State Legislature, they passed a law promoted by the Arizona Center for Policy, I think, saying that a doctor could override that. That if you said, I don't want any support, extreme measures, I want to get off life support, that a doctor could override that. We're not talking about actively helping you suicide. We're talking about being on life support.
Advanced life support.
That's what and this legislation was really not very well advertised or.
Let's let him answer the question.
Discussed. Most people knew nothing about it.
I am unaware of that, to be very honest.
Typical.
And I don't see that happen.
You know, and there is a big push. I don't know if this would do anything with it, but there's something called PULSE, which is physician order,
life-sustaining treatment.
So where you, and it's not in Arizona, but it's in other states, like Washington has this, where you can have a conversation with your primary care physician prior, and a physician can fill it out, and it becomes an order, an actual physician order. Because advanced directives, you can complete those, but it's not an order. It's not, you know, if you don't bring it with you to the hospital, they're gonna, and you don't have the capacity to make a decision, you'll get everything done. Whereas this is actually an order that can be put into a chart, put into a record, so you can have these conversations prior, and I would hope that would trump any of the
I know. For example, there is what is called a pre-hospital medical directive that people can fill out that is an order. That you can call an ambulance, and the ambulance will take great care of you, but if you have it's called an orange form.
Yeah, it's do not resuscitate.
Yeah, and that, I've never heard of that being overridden by.
Well, that's because it's just passed.
Well, that's a really interesting issue, but let's move on.
Yeah, we have another question right here.
Because we've got a lot of questions, I know.
In Atul Gawande's book, Being Mortal, he talks about how in other cultures, like in India, for example, they treat the elderly with the utmost respect. And I was just wondering, do you think that that cultural difference, you know, in America, for example, contributes to why aging is such a struggle here? And do you think that that could ever be changed?
Yeah, interesting question. So, you know, a familial piety is what it's called in India and other Asian countries where, yeah, the elders, you know, that's kind of your duty, being Indian myself, to take care of your parents, to take care of your elders. It is a little different here. It's interesting, we do what's called palliative home care. So we actually go to the home and provide palliative care, not hospice care, but palliative care, right? And we see that a lot. We see a lot of older people, because it's Arizona too, right? They're from the Midwest and their family's in the Midwest, but they move here. And they were healthy when they moved here, and now all of a sudden they have an illness, a terminal illness, chronic disease, and their family's way out there, and they're struggling to kind of make it at home. And we have to engage the family a lot of times and say, hey, this is what's going on. And I definitely think from what we see, it is a contributor to deteriorating health, right? Because then it's difficult, because they don't have that social support. There's even good evidence, actually, that isolation or a lack of social support can lead to worse health outcomes. So increased inflammation, increased cortisol levels, increased stress hormone, basically. Yeah. So, you know, we do see a lot. And for people who don't have a lot of support or family support, they do struggle. We find they struggle more. That's a risk factor, actually, for us.
Yeah, I don't think it's a lack of respect for elders, but you know, we're a mobile society. You know, I have 3 daughters. None of them live in state anymore, and my wife and I complained about that, and they said, "Well, you know, you brought us up to be independent." So, and as Gobi mentioned, you know, the snowbird phenomenon, it is, you know, a statement to their courage and perseverance, but a lot of very sick people come here in the winter. And their families are back in Minnesota or in Iowa or the Northwest, and they get ill, and they get so ill they can't get back unless they have $40,000 to pay for an air ambulance. So I think we're a mobile society, and the families don't stay together. It's just kind of how U.S. society is. And we could go on and on, but caregiving is an enormous burden in this country. It's estimated that $550 billion worth of voluntary care is given by families each year in this country. And I won't go on, we get more questions come up, but we don't pay for that. We don't pay for a place for people to stay, and we don't pay for people to help care for people in their homes. So that comes at the cost of the family in many ways, personal and financial.
Okay. So
The elderly are a vulnerable population, and with the new baby boomer era, a lot of those adults are getting older and kind of get into that hospice level. And what I was kind of wondering is that I feel like that hospice is going to become more of like a for-profit. A lot of for-profit hospice areas are going to be open. So what do you think we could do to, protect the elderly from being mistreated by for-profit hospice, or just, having better health outcomes in general?
Yeah, so I mean, there's probably 50 or 60 hospices here in Phoenix, and maybe 1 or 2 are not-for-profit. Majority are actually for-profit. And I'd say that doesn't necessarily mean they're providing bad care. I really like the way kind of healthcare is moving with value-based care. I don't know if you guys have heard of that. You probably have in your classes, right? So the numerator is quality care, and the denominator basically is cost. So you want increased quality at a decreased cost. Whereas before, healthcare was it was volume, right? You just got paid for the more people you saw. So
that's coming. We're not there yet. But.
Yeah. So value-based care, I think that movement, if we start measuring, even if whether you're for-profit or not-for-profit, we measure you based on your quality, and then that cost outcome, I think we'll be okay. I think then people won't
Did you read the article in Time Magazine? So there was a big article recently in Time Magazine about poor hospice care.
Yeah.
So it definitely exists. And that, capitalism does not work in medical care very well. And you don't roast the whole system based on a few, but there are for-profit hospices that are for-profit hospices, and the care they deliver is not the best. And there are over 4,000 hospice provider companies across the country. That we don't need 4,000. It is a problem. And there are wonderful hospices doing the best they can. It's like any business in the country, but some people take advantage.
We've got another question here.
It seems that within the last 2 weeks, I saw an article in the Arizona Republic about Hospice of the Valley doing a pilot program for actual treatment and hospice care. Is that underway?
It is. Yep. So Medicare. So Medicare started this in 2016. It was a pilot project, and basically it decided to look at hospices taking care of patients. So you still have to have a terminal diagnosis, less than 6 months. You still have to have a physician sign a form, but you can get hospice care at the same time that you get aggressive care. And Medicare is basically looking at it, looking at outcomes, quality outcomes, and cost outcomes. So that started. You have to have straight Medicare. There's a lot of different criteria. So not a lot of people qualify, but for those who qualify, it is an interesting pilot. So Hospice of the Valley is the only one in Arizona doing that right now, or participating.
We ought to pause and let Gobi tell you a little bit about palliative home care and the challenges that a palliative home care program faces from a reimbursement standpoint.
Yeah, so that's a big thing too. So, we go to insurance companies all the time just touting this care, that this is value-based care, right? And trying to get payment for palliative home care, because there is not payment for that right now. And we've actually had a number of insurance companies actually buy in and actually pay for it. And so we're just trying to get it. It would be great at someday where all insurance plans pay for it. But it's a struggle.
Getting reimbursed for providing care at home is very difficult.
It is a struggle.
My question is, currently, how much do family members influence choices at the end of life, and what potential do family members have to contributing to conversations about death and dying?
Enormous, as they should. That you want a family, and some cultures defer to families' decision making. U.S. is a bit different. Kind of autonomy is big in the United States, being able to make your own choice. But certainly there are families who have enormous influence. And one of the ethical dilemmas you're faced with sometimes is called relational autonomy and undue influence. There are times when I'll meet with a patient and I'm by myself with them, and they'll tell me about their own personal goals and what they want to happen. But when the family's around, they don't say the same things. And they kind of bow to the influence of their loved ones. Sometimes they do that lovingly, sometimes they do that in a frustrated way, that the families don't listen. So it's not common, but it's not uncommon, it's not rare. So you have, when you're talking to patients and families, you have to, at times you have to talk to them by themselves and really try to help them voice their own opinion on what they want. Because families can have an enormous influence, both positive, but sometimes not so positive.
Okay, we've got a question here.
So you mentioned that you don't traditionally see the Black community participate in hospice. And I understand that because none of my family has ever done it. I've tried to have the conversation and not to, they believe in, we can pray it away. What message would you give to those to say, trust the system, trust the hospice system, that make it easier versus dying in a hospital?
For good reason. I think there is a bit of a lack of trust for Black populations, and particularly older Black populations. And you just try to do your best to get to know them, develop relationship and trust with them, that they know you're on their side. But sometimes it's really hard to overcome that. So, they have good reasons for their doubt.
Yeah, Tuskegee. Anybody ever heard of that? Yeah. The Tuskegee experiment was a syphilis experiment. We actually had a cure for syphilis. And this study went up to the Surgeon General, and they just wanted to see how African Americans responded to syphilis. They thought, well, maybe they have more neurological symptoms and cardiac symptoms. And they didn't tell any of these patients what they had. So many of these patients actually ended up dying.
They didn't treat them. They didn't treat them.
They didn't treat them. Even though we had a cure, they died of their disease, right? Even though we had a cure, they infected their wives with the disease, and even many children were born with, syphilis as well. And so this is why we have IRB and informed consents now, but you can understand where some of the distrust comes from. There was a study actually for doctors having this conversation about advanced directive, CPR, and do not resuscitate with African American population. And they even included African American physicians, and most African Americans had distrust of the system because they thought, well, is this a way for you to save money? You don't want to spend money on me, So it's just an ongoing, I think, conversation and engaging people. But there are reasons for that.
Yeah, if you want to read a wonderful book, Henrietta Lacks. Have you guys ever read? There's The Immortal Life of Henrietta Lacks. Helix cells. There's a young woman who died from Baltimore, died of cervical cancer at Johns Hopkins. And it really tells this moving, true story of her life and her family and kind of the whole evolution of developing and the reasons for developing informed consent. And it's well worth reading. So The Immortal Life of Henrietta Lacks.
I think we have another question here. Oftentimes when we talk about end-of-life conversations and such, we talk about a societal shift towards rehumanizing death. Oftentimes, I know oncologists from the palliative care side get a little bit of flack because in your training you are told to do whatever means possible for the patient. So to what extent do you think that there is ongoing or needs to be a bigger shift in medical education or training around end-of-life care?
That's a great question. I think I'm an oncologist. I became a palliative care physician because of 30 years of doing oncology consultations, and seeing care I wasn't very comfortable with. Not that I'm by any means perfect, but it bothered me, at least to the point that I wanted to try to do something different. I think we do have to change the culture of how we care for people with advancing serious illness. You look at kind of the whole literature of serious illness. When there's kind of stage 1, stage 2, and stage 3. Stage 1 where sometimes we cure people, heart transplants, treating acute leukemias. They get better, they're cured, and they go on with their lives. Stage 2 is where we're maybe not curative therapies. The burdens of care are becoming more. They get referred to specialists for care, and heart failure people do well for a long time. But we're mortal beings. People enter at some point, stage 3 of advanced illness, where the burdens of care begin to outweigh the benefits. people's functional status begins to decline, their nutritional status begins to decline, frailty starts to set in. It's not hard to see that. And I think that's where the culture needs to change, and palliative care needs to become part of that. I've learned that oncologists have a good heart. They're trying to do the right thing. They develop tremendous relationships with who they're caring for. To be very honest, some of the reasons they keep treating people is they're not capable of having the end-of-life conversation. They literally don't know how to do it. They trip over themselves. And I sit in rooms sometimes as they talk to their patients, and I'm there. I just kind of crawl in the corner when I hear kind of the conversation that happens. So we have to do a better job of educating medical students, pre-medical students, lawyers, and certainly residents and everybody in the skills of kind of primary care, which go become communication skills are a huge part. What is the procedure of palliative medicine? Talking and learning how to talk to people about difficult subjects. And there's just a lot of physicians and caregivers out there that just can't do it. They don't know how. It can be taught. It's been shown that you can teach people.
Right, another question up here.
Hello. We have a couple of Facebook Live feeds going, and we have one person here. Her name is Carolyn Meek, and she's asking, what are the ways in which we currently allow people to make choices for end-of-life care, aside from a DNR? And going forward, who do we think will be responsible for having these conversations, aside from palliative care physicians?
Yeah, and that could even be, disease specific. Like, so DNR obviously is an important conversation, but like for dementia, right? It's important as dementia, if we can catch it early, to have those conversations early with the patient when a patient still has the capacity to make a decision. Because as that dementia gets worse, right, they're not going to be able to make that decision. And so questions, conversations about feeding tubes, right? Would you want a feeding tube? In dementia, end-stage dementia, you're not able to eat. And that's part of how you die. Would you want a feeding tube? And explaining what the benefits and risks of that are. And it's really good to even have a caregiver there for that as well, because, at end-stage dementia, to ask a caregiver, what do you want, that puts a lot of guilt on that person versus being able to instead, what would your husband want if we were able to have a conversation with him before? That's just one example, but.
Yeah, I think what Gobi's talking about is the whole world of advanced care planning.
Yeah.
Medicare now, despite Sarah Palin, kind of set us back several years, but Medicare now pays physicians for advanced care planning visits as of January of 2017. So advanced care planning is to sit down with somebody and talk about how their health and what their illnesses are, honest conversation about prognosis, and as I mentioned, kind of beginning to talk about their mortality and how they might want to be cared for. There is an International Society of Advanced Care Planning and End-of-Life Care. Other countries are way ahead of us. Mayo Clinic is way behind the curve. We have started an initiative with the Center for Palliative Medicine and the Enterprise Ethics Committee to develop a normalized, kind of standardized advanced care planning process for the institution. We don't have that, believe it or not. And the one last comment is, I think you mentioned, who's going to do that? Yeah. It can't be just palliative care physicians. We have to give those skills to primary care physicians, geriatricians. When I talk to groups, and I talk a lot to different churches and such, that I'll tell people that have a doctor, make an appointment to go see your doctor and don't complain about anything. Don't tell them your thumb hurts. Don't tell them you got a runny nose, because if you do, that's what they'll focus on. Go see your doctor. Tell them you want to talk about their health, what they think the prognosis is, and how long do you think I'm going to live. It's really an advanced care planning visit. The doctor can be paid for that now. And so I think that's just tremendously important to be able to do that. And people be, then find another doctor.
Yeah, that's part of why they pay, because these are conversations that it's not a, if you go to a doctor, what's usually 10, 15 minutes, these are conversations that take time.
Yeah, they take time. And you can get reimbursed for 30 minutes, you get reimbursed for the next 30 minutes. You can Medicare they really did a good thing. You can go in with a broken thumb and get that taken care of. In the same day, have an advanced care planning visit, and the doc will get paid for both visits. That doesn't happen in medicine very often.
Yeah, most are not billing for that.
Yeah.
I really appreciate your comments, but I'm thinking of these end-of-life conversations, and who other than physicians can have these conversations? You've emphasized a lot about the physician, the geriatrician, but there are the primary care providers that you've mentioned that are the social worker, the nurse, the psychologist, and sometimes the chaplain, the religious person. And the spiritual care of these patients, I think, is very important, and so that aspect, I think.
I couldn't agree more. And the other part about the Medicare law for advanced care planning visits, that nurses, chaplains, social workers can do it, what we call incident to. Like if I see somebody and I send them to my social worker to have an advanced care planning visit, they can be reimbursed for having that visit from Medicare. And I would also mention families can have these discussions. There's a wonderful game called the Gift of Grace. I would encourage you to maybe buy it. It's not very expensive. There's all these cards, and you sit around with your family, you have some wine, and there are questions about life and end of life and illness and kind of different situations. I've had friends come over for dinner and drinks, and we played the Gift of Grace because it's really kind of fun. It makes you really think, and so families can do that. You can have these conversations with your parents, with your grandparents, and the Gift of Grace can really facilitate those kinds of conversations.
Right, meanwhile, as I was about to walk up, it occurred to me that we haven't talked about the pressure on caregivers, because they do most of the caring, but maybe things get too difficult for them. Should they feel guilty if they can no longer care for a loved one?
Oh, we could go on. Well, I'll start a little bit. I know I ramble sometimes, but that I mentioned that when I first started, that caregiving is a tremendous burden. You brought this up, that again the system doesn't pay for a place for people to go, and it doesn't pay for caregivers. So the burden falls on families. Unless you're very poor, Medicaid will pay for an assisted living place, sometimes even nursing homes, and will pay for aides to come in and out. But you have to be really, really poor to get Medicaid support. Otherwise, the system doesn't pay for it. And so that burden falls upon families. And families, I heard a statistic recently of families with children 18 years or younger in a family, 40% of families in this country are led by a single mother who's the breadwinner. 40%. And for her to have a mother that all of a sudden she has to care for, can't go to work, people can't do that. So it's really a burden. As I mentioned, $550 billion of volunteer work is given by families to caregive in this country. Not only that, but the skills that are needed, medications, hygiene, toileting, taking care of your dad who can't get out of bed, and it's hard.
Challenges, not any easy answers, I think. Maybe, robotics will show us the way, which I think they're experimenting in Japan with that. But we've got one final question.
Hi, I've been in healthcare for 35 years. And what my frustration I'm finding is that we went with Medicare went with the incentive for meaningful use for the Advanced Care Directive, and then they moved to PQRS, and now we're into MIPS to address this issue, and they threw a lot of money at the healthcare system to educate the community, the providers, and it seems like it's a wash because nobody seems to communicate. We've moved into an ACO type of healthcare environment, and when a patient ends up in a facility as a hospital, then you have the hospital that's taking care of the care and figures that, well, the ACO is going to finish up when they get discharged, but there's not somebody,
ACO, what's it?
Accountable Care Organization, I'm sorry. There's just that disconnect from facility to ACO, where the education should have been really directed at the ACO by the time they got to the facility. And so the patient keeps moving back and forth. And I had a patient come into a practice where the surgeon had recommended hospice to the family, and then they're in there for, we're seeing them for a procedure that we did, but the family was like, well, we were never told in the facility. A social worker never came because it was on a weekend. Social worker wasn't there because the hospitals laid off the social workers. And so now it's like the patient's being back and forth, back and forth, back and forth, and the patient's tired, and the providers are tired, and the family's tired. And I think we need some way to get more physicians and facilities and healthcare administrators understanding that you can bill for this. And I think when doctors and the facilities realize that it's billable, might take an initiative.
Yeah, a heck of a last question there.
I mean, you point to care transitions and what's lost in this care transition from a hospital to a skilled nursing facility to a home, and a lack of communication. We're actually trying to work with a couple of ACOs here, in Phoenix, to try to help with some of that, especially in the home setting. It's interesting too about the billing part of these conversations. We did a survey. It's only about 400 or 500 physicians, but it was a pretty good sample size. And this was the ARMA AOMA task force. And very few physicians were actually billing for the conversation. Some didn't even know about it. Some knew about it, but they weren't billing so in theory, it was created so more people would have the conversation, but it's not being done. So I don't know why. But
Time.
I think so,
So
yeah.
you just described the silos of U.S. healthcare. Yeah. And as Gobi said, transitions of care in our health system are really poor. And I'll make a comment. In October 2014, the Institute of Medicine published Dying in America. It's free. You can get online, Institute of Medicine, and their reports. And if you, under search, put Dying in America, you can download this for free. It's several hundred pages, but I would encourage you to read just the executive summary. It describes what you just described, and we need to do a whole lot better of end-of-life care. And that's a wonder. Institute of Medicine studies are wonderful, and that's a wonderful summary of the challenges we're faced with. Lots of commentary about solutions. So it's very worth reading. And the executive summary is not that long.
You're going to have to stop here before Dr. Fitch gives you more reading to say.
Somebody mentioned being mortal. So
Yeah. And our two moderators, thank you so much for helping us out. Swapna and Joe, and it's great. I just think the world of these two people, and we've got two experts in this field that there are not many that know this much about hospice and palliative care. So thank you for coming.
Thank you.